comes into the decision application of evidence to clinical practice. So let's think about the hierarchy of evidence here. And maybe you've seen a diagram like this in the past, which defines how we think about the different sorts of research studies that are out there, with the base of the pyramid being constituted by expert opinion, and what you might read in a review article written by an expert, and it moves up through retrospective and then prospective research, and ultimately the randomized clinical trial or true experiment sitting atop this pyramid. Now, it's also the smallest part of the pyramid because those studies tend to be the hardest to conduct for both resource and logistical reasons, and therefore constitutes a small part of the overall body of literature that we look to for evidence-based practice. However, they are the gold standard in terms of research methodologies, and if you are able to summarize multiple randomized trials, you may even be able to generate a meta-analysis that is even higher than those constituent randomized trials that you take to form that information. Down the pyramid, risk of increasing levels of bias because of a lot of the methodological limitations of those lower level studies. We'll get into all of this in a little bit more detail. So we think of bias in terms of three general forms. There's selection bias, measurement bias, and confounding bias. Selection bias is defined as an association existing between treatment and the likelihood of enrollment or follow-up in a clinical study. And I think really the easiest way to think about selection bias is loss to follow-up, right? That may affect one group of patients who get one treatment more than another. That sort of selection phenomenon is highly impactful in a negative way on the quality of conclusions that you can draw, the validity of the conclusions that you can draw. If there is any sort of systematic bias in the way that folks do or don't follow up. Measurement bias is also really super important, right? It's defined as an association that exists between treatment and the way that variables or outcomes are measured, right? So if there is, for example, recall bias on the part of patients with regards to an exposure history in a retrospective study, that can really impact the way that that you draw your conclusions. So how we measure outcomes, whether it's asking patients about their history of exposures in a retrospective fashion, or how we prospectively measure outcomes. Say, if a surgeon is being relied upon to measure the outcomes of their work, you might suspect that surgeons aren't always the least biased arbiters of their own outcomes. And so when we can blind an outcome assessor to who the surgeon was or what treatment they got, you tend to get less sources of bias leaking into the way that we measure those variables of interest. And finally, we have confounding bias. And this is defined as changes in the true association between treatment and outcome due to an external or third factor that's associated with both treatment and outcome. This is super prevalent in clinical research, right? The decision, for example, about whether you decide to fix an open tibia fracture with an IM nail or an external fixator is likely confounded by the severity of the injury, right? Injury severity both affects the decision on treatment, and it also has an independent effect on the likelihood of reoperation. And so controlling for confounding factors is critical to generating causal inferences from your research. Now, how do we limit bias in surgical research? Well, we can do it in the design phase of study by randomizing the study, for example, randomizing patients to treatment or outcome generates that true experimental scenario that we like, that we will often be searching for in high quality clinical research. If you're randomizing, you'd like to conceal the randomization so that the residents in the middle of the night don't try to game the system and only select the randomized treatment. That's a little bit easier to implement in the middle of the night. You need blinded and independent assessors of outcomes. We talked about the importance of that in limiting measurement bias. We try to establish objective outcomes, right? Those that are less susceptible to the subjectivity. Completeness of follow-up is very important. That gets at that selection bias phenomenon that we were talking about earlier. And then balancing surgeon experience. So some of the treatments that we might be interested in investigating aren't the same as randomizing a patient to a placebo versus an active agent pill. Surgical interventions are really complex interventions, and in making sure that there's an adequate balance of surgeon experience, or that we're accounting for surgeon experience when we're trying to determine whether that's whether a treatment is effective or not. Very, very important. That's gets at this idea of expertise bias. Now, how can we design studies that aren't randomized to still take some of the bias that may be occurring out of those studies when we are unable to randomize? So we can match patients or restrict patients, right? So matching patients would be taking, if we were interested in looking at external fixation versus IM nailing, we might want to match patients on factors that we think may be confounding variables. We also can restrict our analysis. So, if we're interested in removing the bias that may be coming from age, for example, as a confounder, we can restrict our analysis only to younger patients, right? To try to mitigate the confounding effect of age. We can still select blinded or independent assessors, objectively assess outcomes, make sure that we're obtaining as complete a follow-up as possible, and we can still adjust for or account for surgeon expertise. Now, how about after the design phase? Are there steps that we can take in analyzing our data that can control for sources of bias? Well, mentioned a couple of these earlier. Matching we can match in the analysis phase as well as in the design phase. We can stratify our analysis, or we can perform multivariable regression to introduce potentially confounding variables into our models, or adjust for them by stratification, thereby removing the confounding effect. So, coming back to our hierarchy then, let's talk about a few of these study designs and how they actually work. So let's think about open tibia fractures. A few years ago, we were interested in trying to understand the best therapeutic approach for open tibia fractures, that being either intramedullary nailing or external fixation with our partners in Tanzania. We designed a randomized controlled trial. And what happens in a randomized controlled trial is that we start with the diagnosis of an open tibia fracture. We defined comparator treatments, and we randomize patients to one of those two treatments. And when we randomize, the magic of randomization really comes from the balancing of both known and unknown potentially confounding factors between treatment groups. And so that is, that equal probability of receiving one or the other treatment allows us this very powerful design feature for mitigating the bias that creeps in from those extraneous factors that can confound our inferences. Now, randomized trials aren't always feasible, right? There can be ethical issues. It may not be ethical to randomize a patient to, for example, amputation versus limb reconstruction for high extremity, high energy, lower extremity trauma. You may not have the buy-in from surgeons or patients. The outcomes may be too rare. So we may never detect enough events to adequately recruit for a study. So we may want to look at a different type of design for assessing impact. Infections are often, hopefully a rare enough outcome, but sometimes powering a study prospectively to detect differences in infection rates by treatment just may not be feasible. And so you have to look at another more efficient studies strategy. You may not have surgeon buy-in. There may be differential expertise in one or another treatment. The primary question may not really care about understanding therapeutic effects, but rather we may be interested in, for example, identifying risk factors for a particular outcome and cost, right? We may never be able to raise enough money to pull off this study. So what do? We can look into our toolbox of other potential design strategies when the randomized trial isn't possible. And so the next rung in our hierarchy of evidence is a prospective cohort study, which really retains a lot of the features of a well-constructed randomized controlled trial. However, we don't have that magic randomization, that equal probability of distributing not only the treatment, but all of the potential confounding factors that are out there. We still start with the diagnosis and follow patients forward in time, but because what we call the treatment mechanism is not random, we have to account for other potential factors that introduce bias. And then we have to get into those analysis features that we talked about earlier to properly design an analysis plan that takes into account those sources of bias, like confounding bias, and adjusts for them. How about if a prospective cohort study isn't possible? And sometimes that's the case because for some of the same reasons that a randomized trial may not be possible, is because the prospective cohort study still is a labor-intensive undertaking that takes a lot of time. You have to follow the patients from the time of enrollment in the study, often for a long period of time later. That can be time and cost and resource prohibitive and require us to look at retrospective designs. Okay, so let's talk now about the case control or some of the retrospective cohort study designs. So a retrospective cohort study, and I'm gonna define this as a different entity than the case control study. A retrospective cohort study looks a lot in this diagram like a prospective cohort study. However, we start later in time after patients have already been assigned to one or another treatment. In this example, an IM nail versus an external fixator for an open fracture. And we look backward in time. So, right, we might have a clinic in which we've been following patients with open tibia fractures for many years. And we look at our patients and we identify them based on what treatment they received. And we go back in time and we look at, and we will already, by definition, have measured outcomes on these patients because we've got this clinic where patients have been following up for many years. And we go back in time and we identify various risk factors and run an analysis, again, taking into account potentially confounding factors when we try to understand the superiority of one or the other treatment. This is a different type of study design than a case control. And I see these terms confused a lot in the literature, and I want to make sure that you understand the difference between a retrospective retrospective cohort study and a case control study, which is also a retrospective design. The case control study is a special case of a retrospective study design that identifies patients based on their outcomes, right? So rather than looking at looking at my clinic, where I have patients that I've followed for years and years, and identifying patients based on the treatment they received, we go back and we look at patients based on the particular outcome. The case control study design is a particularly useful methodology for studying risk factors for rare outcomes, okay? And so in this case, we're looking at infections, right? We may only have an 8% infection rate in our study population of tibia fractures. And so rather than looking at all of the patients who had an IM nail versus an external fixator, which could be incredibly time consuming in this clinic where I'm following, hundreds, maybe thousands of patients who've had open tibia fractures, I identified patients based on whether they had an infection or not. Okay, so we're looking for the infection outcomes, and for each patient with an infection, we identify patients who didn't develop an infection and try to understand the differences in their exposure profile to try to understand prognostic factors that put patients at risk for infection. So a very efficient study design, but also fraught with a lot of those biases that we had talked about initially, at risk for that. And so really need to carefully execute case control studies in a way that really identify the appropriate controls, which in this case are patients who did not develop an infection, right, in a non-biased way. Now, revisiting our hierarchy of evidence here, we've kind of marched on down the various rungs in this ladder and identified the increasing sources of risk as we march down that hierarchy of evidence. We've talked about the types of bias, again, selection bias, measurement bias, and confounding, and how these can really jeopardize the validity of our inferences from our research. And we've talked about both design phase and analysis phase interventions that can help us limit the bias. So again, this talk has really summarized how we get from the development, that developed study question, that good study question that follows the PICO format that you've been introduced to, and gets you to the proposal phase of your research. And in the next talks, you're going to hear how to take that proposal and actually implement your study and take it all the way through its execution and dissemination of your findings. Thanks again for your attention, and we'll see you soon.
Okay, we have one more talk from Dr. Morshed, who will then be joining us for questions afterwards. So if you do have questions, feel free to post them in the chat or save them for the conversation that will follow this next talk.
Hi there, this is Saam Morshed again, and we're gonna now talk about implementing your research and talk about some practical issues in taking your proposal to your protocol. The learning objectives of this presentation are going to be practical issues around implementing your well-conceived study question that has become a good proposal, and now we'd like to roll that into actually actionizing, implementing and putting your proposal into action. It requires that we consider funding questions. We're going to talk a little bit about building your research team, trialing your protocol, troubleshooting your design in order to identify problems that may arise, running your trial, and talking about some simple design or data management issues. So we're going to take a case example of a study that we've completed with our partners in Tanzania. It's a question that's stated as whether there's a difference in reoperation comparing external fixation to intramedullary nailing for open tibial fractures. We've defined a population of tibial shaft fractures, the intervention, a locked intramedullary nail, its comparator, which is an external fixator, and we're measuring outcomes that include primarily reoperation within the 1-year follow-up window, and secondarily functional and patient-reported outcomes, as well as clinical union and radiographic union. So funded. Doing prospective clinical research is not cheap, it's not free, and it requires that we get funding in order to bring about the resources that will be required to carry out the study. We need to determine an ideal budget. This is what I always like to do, is think about the ideal study that would definitively answer a question, and then from there begin to scale it back to the minimum feasible amount of funding that we need to implement a study that could answer our research question. We need to identify potential sources of funding. They may come from your institution, they may come from foundations or professional societies, and often the big ticket funders include government and sometimes NGOs. You want to cast the wide net and be persistent. It often means starting small and building your bank account with subsequent rounds of applications and grants for funding. Building a research team is incredibly crucial. If you're new to conducting research, it means identifying the right mentors, teachers, and the folks who are going to provide some guidance to you as you carry around about your research, identifying collaborators and partners, co-investigators, and importantly, research coordinators who will do a lot of the data collection, patient enrollment, and follow-ups. Most of us as busy clinicians just aren't able to be there and carry out every little step that it takes to get patients into our study and followed up appropriately. And so identifying and hiring research coordinators is absolutely critical to carrying out and implementing your research. This is a research team that we built at the Muhimbili Orthopaedic Institute in Dar es Salaam, Tanzania. We had a group of 4 surgeons that were involved. We had 2 surgeons from UCSF, a resident, and several students that we had that were able to spend time visiting MOI. And we had a team of 3 research coordinators that we brought on almost 10 years ago now, that have continued to be a wealth of resource and have become incredibly skilled research coordinators that really rival some of our teams here that we work with domestically. So this team was assembled about 10 years ago now, and has continued to work together on trial after trial. This particular research study that we conducted started with the development of our team in 2014. We proposed an initial round of grants for funding in 2015, which we were lucky enough to secure. We developed research protocols and what we call a manual of operations. We developed our case report forms, which are the forms that are completed with information on patients when they're enrolled and at each subsequent follow-up. We got human subjects approval towards the end of 2015, and were able to begin enrolling patients in 2016. Finished enrollment towards the middle of 2017. And completed final 12-month follow-ups in 2018, which allowed for analysis and completion of our initial manuscripts later in 2018. So this is what the study timeline looked like. Something that you should begin to be thinking about even when you're proposing your research and writing your grants. Those are the sorts of things that funders are going to want to see to establish feasibility. Now, how do you screen and enroll patients? This is one of the most critical elements of operationalizing your research protocol, is really thinking through how new cases will be identified. When will screening be conducted and by whom? This requires clinical expertise. Informed consent is a critical element in carrying out this work. You need to be able to establish protocols for confirming that informed consent is actually being conducted prior to enrollment and randomization of patients in your study. You need to have a good mechanism for gathering baseline data, including demographic information and treatment information, and establish a sequence within which treatment assignment is going to be randomized after patients have been properly screened and informed consent has been performed. Having a pilot or a run-in period in your protocol is really critical for making sure that it's feasible, that you actually are able to enroll the sorts of patients that you thought you'd be able to get from screening. Often this is a big difference, right? You may treat a lot of patients with a given condition, but you need to make sure that those patients can actually fully meet the inclusion criteria and are willing to participate in the work. You need to look at whether your randomization works, whether the randomization is truly concealed and is allocated properly. You need to see whether your study procedures are working. Are the ways in which you're implementing the surgical treatments that you might be randomizing patients to actually working as expected? Are there barriers to follow-up, and how can those be overcome? And data quality issues will certainly arise, and you need to be able to detect those and correct them in real time. So this is how the follow-up schedule for our patients enrolled in our open tibia trial looked like, right? And we needed to make sure that we could get patients back at each of these predetermined follow-ups and gather the appropriate follow-up information, including imaging and patient-reported outcomes. You want to eliminate barriers for patients who are coming back to clinic. How do you do this? Well, we were able to create a dedicated research clinic, which required that we hire not just the coordinators who are going to come and gather the information, but also nurses, and making sure that one of our partnering attendings was able to staff that clinic. This requires building trust and relationships. How do we reduce costs to patients, right? Because if those patients are paying money to come and follow up, and that's a barrier. Often patients won't come back for follow-up visits because they're required to pay more. We would make those clinics free to patients to incentivize them to come, making any imaging studies that they would need at the time of those follow-up visits. Also making that free of charge for the patients so that they have an incentive to show up for their follow-up visits, and making sure that we were implementing technologies available to patients, including cell phones, making sure that they were getting called up or using SMS reminders. How do we get patients who are lost to follow-up back? Well, you collect a lot of information right at the get-go, right? Patient information. What are members of their families? If they live in a community, can they provide information on community leaders that can help us track these patients down? Narrative addresses, right? Sometimes patients may not have an actual street address, and so we need to get information documented that provides a narrative as to how one could find them. Not only where they live, but where they will recover from their injuries. Staying in touch by phone and identifying potential barriers as they come up, and considering transporting patients or providing them a stipend for transfer back if they're coming from a distance. Are there reasons why ways in which we may be able to leverage technologies like cell phone photos and telephone surveys that may be valid surrogates for the outcomes that we're interested in collecting on these patients? This is an example form that we used in one of our studies, which really shows all of the various parameters of identifying information that we collect on these patients, including narrative descriptions on where they live that you can see at the bottom. What do you do? Do we collect paper forms or go electronic? Well, we found out very early on that paper forms were really problematic at getting printers, filing these papers away. A lot of that paper could be done away with the emergence of high capture, which helped us overcome the nightmarish chart storage process that you can see here in one of the medical records rooms at Billy. All of our information was put on research laptops and uploaded to the cloud. This can be done at relatively low expense and allows for capture of both information that the coordinators are implementing on background, as well as patient-reported outcomes, which would go directly onto the research laptop and into the cloud, and imaging studies, which also could be uploaded directly to our electronic data capture system. We use a system called REDCap, which allows for free web-based data collection. It's widely available, completely customizable, password protected to the highest level of protection of human subjects' information, and is really become the gold standard for electronic data capture. It allows for randomization, follow-up scheduling, and real-time data reporting. How about data monitoring? We have to have a plan for how data will be stored and monitored. What are the intervals of analysis? Typically, we will do interim analyses every 6 months. We'll want to have a schedule and a customized way of reporting this data out to a data safety and monitoring board. We talked about that in one of the other lectures as a necessary safety measure for that's really now being required in most prospective clinical trials. This is an external body, again, that looks over, not affiliated with the study. And what they are doing is they're providing oversight and a separate set of eyes to make sure that patient safety and adverse event reporting are being appropriately conducted, that there may be certain stopping rules that are implemented a priori at the beginning of a trial that need to be monitored and checked for compliance over the course of the study. These sorts of data safety and monitoring boards need a feed of information from the trial, and one will want to make sure that those routines are being set up at the beginning of the trial to make sure that best practices are being followed. Adjudication. A final review of all study primary events or complications is really, really important. And this needs to happen iteratively over the course of the trial. You need to have an agreed upon set of parameters by which a study event, such as an infection or a reoperation, are adjudicated, and proper recording of outcomes is being followed by an adjudication process. The investigators will review events and develop a consensus as to whether a certain potential event that's being flagged on the follow-up forms counts as a primary event, right? For example, did a patient in fact have a fracture-related infection? If that happens to be our outcome of interest, sometimes ascertaining a fracture-related infection can be somewhat subjective. So adjudicators will want to get together, review the information, and ascertain whether the event is related to participation in the study or not. Same goes with adverse outcomes, right? Those are also events of interest. They need to be reported to the Data Safety and Monitoring Board. They need to be potentially reported to the human subjects review committees at participating institutions. These fall within the purview of an adjudication committee. And this is just a consort diagram that came from our published primary results from our randomized trial comparing intramedullary fixation to external fixators. You'll want to be able to send every patient in the study from the initial screening process into one of these final boxes in a form like this that is required now for publication of your results. So in summary, I know we've talked a lot about a lot of different subjects, and I think it's hopefully this slide brings it home for you. Remember funding and thinking creatively and iteratively about funding your research, how it must, it often comes from several different sources, and we kind of use smaller funds to build grants for bigger funding and so on and so forth until you gather the resources that you're going to need to carry out your research. Building a robust research team, really the people really matter. Finding the right collaborators, developing a team of coordinators that can safely, ethically, and diligently carry out your research. Trialing your protocol, identifying potential problems in your protocol before you roll out your larger clinical trial, and then tending to data management and quality control over the course of your study will get you to the point where you've got a high quality product for analysis and ultimate dissemination and publication of your findings. Remember to get those final follow-ups. They really matter. So we're coming towards the end of our kind of framework here that we've created, which started with an idea about a good study question that we were able to manicure in a way that allowed for a hypothesis that was actually testable, developing the right kind of proposal or protocol which implements all of the design features that we have in our toolbox, as well as analytical approaches, taking that proposal for research and taking it through to a protocol that we can implement, complete, and ultimately disseminate as valid answers to our original research question. Thanks very much for your attention. I hope you found this presentation informative.
So that was Dr. Morshed. I just heard from him. He's running a little bit behind from the OR. So he's going to be able to join hopefully in the next 5 to 10 minutes. We originally had a break scheduled for shortly after he's done before we start our final presentation of the day from Dr. Nelson. So I think we're going to do our break first. So I just encourage you, if you have questions, please put them in the chat, and we'll do a short question and answer session prior to Dr. Nelson's final talk. Thank you guys for sticking through the research methodology section. We'll have one more talk from Dr. Swankowski and Dr. Woolley tomorrow on publishing as well, to kind of complete this series. And then as well on Saturday, we'll focus on a lot of research being done currently in Haiti as well. So I'm going to put up the slides on the translation features for the next 5 minutes, but we'll plan on coming back around 5:05 Haiti time for a short quick question and answer session about Dr. Morshed's talks, and then our final talk of the day with Dr. Nelson.
Alors,
Awesome. Welcome back, everyone. So I don't believe Dr. Morshed is going to be able to join in the short term. And so in the interest of time, I want to make sure that we're able to get to our final talk as well. So we'll have Dr. Nelson's presentation and as well as his question and answer session. But if you do have any questions for Dr. Morshed, please put them in the chat. I'll make sure that we get responses to those and disseminate them to the group as well. As I'll put together, I know several people have put contact information if you're interested in getting connected to mentorship or things like that to be able to conduct research of your own. And so I'll put together a little document with all the information that we've heard of today and distributed that as well to people that are interested in connecting with different mentors or different organizations that might be able to help offer mentorship throughout the process of conducting research. So without further ado, Dr. Nelson is here with us today, and I will prepare his presentation, and we'll have a question and answer session with him upon its completion afterwards.
Bonsoir tout le monde. I would like to thank Vincent Michel especially and all of you who organized this course for putting this together and for inviting me to be part of this, and also for allowing me to be part of the Haitian orthopedic community. Both are a great privilege, and I'm very excited to share some of my experience with osteotomies using intramedullary fixation, specifically the sign nail. And greetings from Dr. Jackie and I at the Haiti Adventist Hospital. We've been privileged to interact with the residents coming from HEUH who have been really helping us with the responsibilities we have running a busy orthopedic service. The objectives of my talk are to give you a really basic foundation of analyzing deformity, and then introduce you to an exciting topic called fixator-assisted nailing, and talk a little bit about the techniques of doing percutaneous osteotomy using the sign nail. First of all, we're going to start out with the basics of deformity analysis, and I've narrowed this down to 3 steps. The first one is to measure the mechanical axis deviation. And this answers the question as to whether or not there is a deformity and how bad that deformity is. And then the second step is to find out which bones are involved, one or both tibia, femur being involved. And this involves measuring the joint line orientation angles. And step 3 is finding out specifically where the apex is so you can plan where to make your osteotomy and how to place the fixation. So mechanical axis deviation is measured by drawing a line from the center of the femoral head to the center of the ankle. And this tells us if we have a varus deformity or a valgus deformity, or if we have normal alignment. And it also gives us a way to objectively measure how severe it is. And the normal deviation of this line is about 0 to 10 millimeters medial to the center of the knee. And in this patient, we see that these lines drawn from the center of the hip to the center of the ankle don't pass through the middle of the knee. And we measure the distance between the center of the knee and that line to get our mechanical axis deviation. On the right side, on his right side, we have 48 millimeters of varus. On the left, 32 millimeters of valgus. We write this in our chart just like this, as if we're looking at the x-ray. 48 varus / 32 valgus. So many of you, like our hospital, probably don't have the luxury of being able to take a long x-ray. And at my hospital in the United States, we have a special machine for this. But in Haiti, it can be difficult to get the entire lower limb on one film. And we get films like this, and we have to do the same type of analysis. And there's a way to do this that involves measuring the anatomic tibiofemoral angle. So that's a line down the shaft of the femur and a line through the shaft of the tibia. Normally, these make a 6-degree angle to each other. In the X-ray on the left, these two lines are 20 degrees to each other, showing that we have a valgus deformity. So that's step 1. Before I introduce you to step 2, we need to take a pause and talk about the difference of mechanical axis and anatomic axis. In a way, these are two different languages, just like French and Creole. Some words are the same, some words are different. The mechanical axis in the femur is different than the anatomic axis in the femur, but in the tibia, they're more or less synonymous. The mechanical axis is defined by a line drawn from the center of the femoral head to the center of the knee, or I should just say more generally, the center of one joint to the center of another joint. We talked about the mechanical axis of the lower extremity, and that was from the center of the hip to the center of the ankle. Now I'm talking to you about a different mechanical axis, which is the center of the hip to the center of the knee, called the femoral mechanical axis. And the anatomic axis of the femur is a mid-diaphyseal line. In the tibia, it's very easy because these lines are almost exactly the same, and we can just consider them the same for all practical purposes. So that is to say that a line from the center of the knee to the center of the ankle is more or less the same as a line straight down the tibia shaft. So now you're ready for step 2. We determine that there's a varus or a valgus deformity, and we want to know if that deformity is coming from the femur or coming from the tibia. I'm not going to introduce you to all of the angles, but we need to know just a few of the most important ones. And in the femur, the mechanical, which is the small m here, stands for mechanical, lateral distal femoral angle is 88 degrees. That's a line through the joint, makes an 88-degree angle with the mechanical axis of the femur. And in the tibia, the MPTA, which stands for medial proximal tibia angle, makes an 87-degree angle with the joint line. So remember that for the moment, and then I'm going to introduce you to one more angle. So we have 88 and 87, and now I have to talk to you about 81. So in the femur, we also have the anatomic axis that we just talked about, and that is at a 7-degree angle from the mechanical axis. And so if we make a 88-degree angle with our joint down here, or the mechanical lateral distal femoral angle, you can subtract 7 degrees from that to get the anatomic lateral distal femoral angle of 81 degrees. And that's important for us, especially as surgeons working in Haiti, because we don't always have an X-ray showing the femoral head and the knee on the same view. So in this example, we ask ourselves, this is step 2 still, we asked ourselves, is this deformity coming from the femur or is it coming from the tibia? Well, we measured the femoral anatomic lateral distal femoral angle, and it's 74 degrees. The medial proximal tibial angle is 87 degrees. So that tells us that this valgus deformity here is a result of a deformity in the femur. Sometimes it seems obvious, sometimes it's not so obvious, and sometimes you can have an obvious deformity in one bone and a more minor deformity in the other bone and not realize it until you measure these angles. And so it's really important to always measure these angles. Again, this is normal, and this here should be 81 degrees, and it's 74 degrees. So in step 3, we have found out already in step 1 that we have a varus deformity or a valgus deformity. And then in step 2, we found out that the deformity is in either the femur or in the tibia. And in step 3, we're determining where the apex is. And so in order to do that, we have to draw a proximal axis and a distal axis and determine where those lines cross each other. In the femur, you can use a mechanical terminology to measure that, or you can use anatomic terminology. And in this lecture, I'm going to focus mostly on anatomic because with the types of x-rays not being able to see all the joints, it's more difficult to plan with mechanical axis planning. And also for intramedullary fixation, the anatomic axis planning using mid-diaphyseal lines makes a little bit better sense. So in step 3, we draw a proximal line and a distal line, and we look at where those cross. And in this x-ray, it's quite obvious where this apex is. Sometimes it's difficult to know exactly where to draw this line, especially if it's very close to the joint. So that's why we use the normal 87-degree angle here to help us determine where this proximal axis is. So there's the proximal axis and the distal axis and the point where they cross, determining where the apex is, and that will help us plan our operation. So back to this example, if we want to find the apex here, it's actually not quite as obvious. And so what we do is we draw a proximal anatomic axis down the mid-diaphysis, and then we're going to use the normal anatomic lateral distal femoral angle of 81 degrees to determine where this orange line is right here. So this is the normal axis of the distal segment, which is the joint and the tibia down here. And that crosses the proximal axis right at this point here, and that's where our apex is. So the reason we couldn't really see where that apex was is because it's very close to the joint. And it's not surprising because this was a physeal problem that caused this deformity, which was, we tried to treat it with an 8-plate, but it wasn't quite enough. And the knee was still invalgus even at the end of growth. And so this patient we treated with an intramedullary correction. So now I'm going to introduce you to fixate way to improve the precision of your surgery and be able to better assess the correction that you're doing on the table. So this is a technique that was developed by Dr. Paley and Herzenberg and written up in 1994 in the, 1997 in the Journal of Techniques and Orthopaedics. And for a deformity like this, the plan is to do a retrograde fixator assisted sign nail. And we're going to hinge this osteotomy at the apex, but we can't cut our osteotomy at the apex. So we have to think about what is that going to look like? We're going to take a little break for just a minute and look at our hardware and determine, that helps us determine where we have to make the osteotomy. So this is the sign nail. The interlock here and the interlock on the proximal end are just under 40 millimeters from the distal end of the nail. So that's an important fact to keep in mind because you don't want to make your osteotomy too far away from that apex. You want it as close as you can to the apex, but we need to have good fixation. So this osteotomy where there's an apex that's in the distal part of the bone in this area, you still have to make it at least 6 centimeters above the joint line in order to allow for a little bit of bone between your osteotomy and the interlock screw and allow yourself to be able to countersink the nail inside the joint in order to avoid having the nail prominent in the joint. We had one of those come to our hospital not too long ago, and it's not a pretty sight if you leave the nail hanging out of the distal end of the femur. So this is where we will plan to cut our osteotomy. And here again is our deformity and the apex. And in order for our final goal of having the orange line superimpose on the red line, we'll have to displace this osteotomy the distance that we see here between these two lines. And we're going to hinge it around this way, around that hinge point, and the distal fragment's going to displace laterally. In order to visualize this, we often use the Bone Ninja app, and you can download this on the App Store for your iPad. And it's really a helpful way to visualize some of these corrections. So cutting our bone at that level, we want to line up the blue line and the green line here. And this is what it looks like, is that osteotomy is correcting into completely neutral alignment there. And you can see how this distal fragment's displacing laterally as it rotates around that apex. If we cut the osteotomy too high up at this level right here, you can see what will happen here when we correct it. The canal, if we hinge it around here, you're going to have too much displacement and you're not going to be able to get a rod through the bone. So in this case, here is our correction, and we have enough bone there for 2 sine nail interlocks. We have the displacement. We lodge the corner of that distal fragment up into the medullary canal, and it's very stable. And we achieved 81 degrees anatomic lateral distal femoral angle. So here's another case. We'll go through the 3 steps very briefly. We have a valgus deformity on the right side with a mechanical axis deviation of 33 millimeters. And so then we want to look and see if that comes from the femur or from the tibia. So we measure our MPTA on both sides and our LDFA on both sides. The X-ray didn't show up perfectly here, so I drew out where the femoral heads are for you. So you can see this was a mechanical analysis here, and we have a mechanical LDFA of 77 degrees. I should have a small M right here. So on the right side, we have a femur valgus. On the left side, we have a normal femur, and we have bilateral normal tibias. And now we do step 3 to analyze where the apex of this deformity is. This was from an old trauma, and it occurred from a fracture that was at this level, and this apex is higher than we had in the last case. Nonetheless, we still cut our osteotomy, not actually right at the apex, but a little bit below the apex, and displaced our osteotomy in the other direction in order to be correcting around this apex. So this apex is a thumbtack, and we want to correct that osteotomy, hinging it around that apex, independent of where our osteotomy is. It hinges on this point to get normal alignment between the proximal and distal axis. And that actually created a little bit of displacement at our osteotomy site, which sometimes can be desirable because this corner can pot itself down in the bone. And in this case, we put a blocking screw right here. That helps to maintain this fragment in its new position of rotation. And that blocking screw should always go on the concavity of the original deformity. So I'm going to go back to the last X-ray. This is the concavity, it's lateral. And as we change the position of that bone, we put a blocking screw here to hold the bone out this way to the lateral side. And in this case, I even took the jig off of the sine nail jig, and I put my interlock screws at an oblique angle to prevent that bone from angling back into the valgus position that it was before. Because the slotted interlocks there have a little bit of play in them. And this was actually an antegrade correction. So I needed to use the oblong holes there, and I put them in at an angle. So I actually didn't have to remove the jig. That was the distal end of that nail. And I use a goniometer in surgery. We have sterile goniometers to measure the exact position. And I'm going to show you how we mount the external fixator. This would have been another option if we cut the osteotomy right at the apex, but that would create a pure opening wedge osteotomy. And if you have pure opening wedge for intramedullary correction, it's not as good as if you have a osteotomy down lower where you can place this corner down into the metaphysis a little bit and get better bony opposition, because here we have just barely the medial cortex touching. And although the mechanics of it are correct, biologically, it would be challenging for this bone to heal completely. And here's the post-op X-ray from that case. And then several months later, we see good consolidation around that nail. Still with some radiolucency on the lateral side, but there was enough consolidation on the medial, anterior, and posterior aspects that the bone was very strong. The patient was asymptomatic. Here's another patient with a 20 8 millimeter valgus deformity. And this was then analyzed with step 2, finding out that we had valgus deformity of the right femur, apex right there. And we start with our correction by putting a guide wire in the distal femur and aiming it in the direction that we want it to go. We started in this case a little bit to the lateral side because we have a little bit more room to put our guide wire. If we start medially for this, it bottoms out on the cortex right here, and we don't have as much room for our nail to go through the canal. So for correcting a valgus deformity, you should start it just a little bit on the lateral side. Make sure you cut your osteotomy 6 centimeters above for these distal centered osteotomies. And then we rotate around the same hinge point there. So we put the insertion equipment into the distal femur. We use a guide wire and a cannulated drill bit to enter the distal femur. The sign nail just has the awl, and it's sometimes difficult to get that starting point started in the distal femur. So you can just use a guide wire and cannulated drill bit for that to make a hole in the distal femur. And then we place 2 points of fixation in the distal femur for our external fixator, and 1 point in the proximal femur above where the nail is going to go. And then we put the osteotome through just a very small 1 centimeter incision. You don't want to use a saw for this. You don't want to open up the osteotomy very much. We just drill a few holes and then put the osteotome there and crack the bone in as biologically friendly manner possible. And here we get the alignment with our external fixator, and then we check that by stretching our cautery cord over that area and make sure that the alignment between the hip and the ankle matches through the middle of the knee. So this is our electrocautery cord at the hip, and down here we check the ankle next, and then we look at the knee and make sure it goes right through the middle, and then our alignment is set perfect. And notice we have the knee in full extension when we do this, but when we put the nail in, we have to bend the knee, and it's more difficult to assess the alignment when the knee is bent. So you get the alignment set when it's straight, have your fixator on it, lock it down, and then you can put your nail in. We put a blocking screw in here to force this femur to stay in varus. And then we advance our nail, and we've rotated around the hinge point, which is distal here in this case, and displaced it appropriately. We use 2 blocking screws in this case. And this is actually a different nail than a sign nail, but the concept is the same. Here's a remnant of where we had our external fixator pin just anterior to where the nail goes. And here's this final result. We left this patient in just a little bit of varus because they have arthritis in their lateral compartment, and we wanted to protect them and overcorrect it a little bit so they put more weight through the medial compartment. And we're going to go through just a couple cases, really, a couple more cases really quick because time is running out. This is a patient that has varus and valgus. We did step 2. We determined that there's deformity in both femurs and in the right tibia. And this is a case where we then analyze step 3 to analyze the apex. And using the deformity correction principles already discussed, we did bilateral retrograde, fixator-assisted nailings. And for the tibia, I opted to do a talar spatial frame because these are a nice way to really dial things in exact. In the tibia, the fixator-assisted nailings are certainly possible, but after we already did it in the femur, even if we're a couple degrees off in the femur, we can put the TSF on and dial the degrees in exactly where we want it to get perfectly straight legs. So the benefits of intramedullary fixation are that they can accommodate translation at the osteotomy site in other words, at your osteotomy, when it's not right in the same level as the apex, you need to have translation, and you can translate the bone to a certain extent, and it works nicely for that. It's also very minimally invasive. We use small incisions. It's biologically friendly. It allows full weight bearing immediately in most cases, and it heals quite rapidly. Sometimes we combine this with lengthening over nail. I wrote an article about this in the Journal of the American Academy of Orthopaedic Surgeons. And this actually explains what we're talking about here in this lecture. But in the article, we are actually using a special magnetic lengthening nail because this patient has a limb length discrepancy in addition to the varus deformity. So this case is different than some of the others because this is varus instead of the valgus that you previously saw, but there's step one. Step two, measuring the femoral angles and the tibial angles on each side. We found out that it's the femur that has the issue here. And then we found out where the apex was, right down by the physis, because this was also from a physeal arrest. The measuring length of the lower extremities is another topic that hopefully we'll get to go over at some other occasion, but overall she had a 28 millimeter limb length difference at the femoral heads that we wanted to make up for. There are several options to treat this. Not all of them are always available for us, but this one we chose to treat with a magnetic lengthening nail. We've actually used this at Hôpital Adventiste. It's quite expensive, but we were able to get a donation and take care of one of our patients at our hospital with one of these nails. Using the fixator, we cut the bone, angled it into varus, rotating around the apex. So there's some displacement there that we programmed into this. And then put a blocking screw here, which is on the medial side now because it was varus that was in the concavity. And now the fixator is removed. And here's the result after surgery. And you can see some interesting mechanism in here that's activated by a magnet. And the patient applies a magnetic device 3 times a day at her house. And this lengthens about 1 millimeter per day. And new bone is formed, restoring both her length and alignment. There she is after full healing. And so again, thank you. I'd just like to summarize with the key technical points that it's important to do thorough preoperative planning, confirm your implant and your bone size. The sign nail comes anywhere from 8 to 12 millimeters in diameter and from about 200 millimeters to 420 in length. And then using the fixator assisted technique, you can be much more precise and really have a nice correction exactly as you expect and as the patient expects. And by performing a percutaneous osteotomy at the proper level, it minimizes pain and maximizes rapid return to function. And then don't forget the blocking screws go into the concave side of the deformity. And thank you very much. This is our sister hospital in Loma Linda, California, where I do some intermittent work as well. And they've really helped to support the program that we have at Hôpital Adventiste. And we hope to use these resources to help all of you and continue to collaborate as we all face the challenges of Haiti together as a team. So thank you very much. And hopefully I will be present with you during the final rendition of this talk and be able to answer any questions that you may have. Very good. Thank you.
Awesome. Thank you, Dr. Nelson, for that. And Dr. Nelson is indeed here as well in person. So if you have any other questions, please put them in the chat or feel free to unmute and ask them yourself.
There are perhaps a few questions here that I didn't get answered during the talk that came up in the chat, and I could just mention a few points if you're interested. One question was why choose an antegrade against a retrograde nailing approach? I think for the distal femoral deformities, the fixation's much more secure if you can use a retrograde approach. And that's where the advantage of the fixator assisted nailing really comes in, because you can extend the knee and be able to really accurately assess your alignment when you're using fluoroscopy. And it really is essential to use fluoroscopy for these types of cases. It's probably possible to do them to a certain extent if there's some severe deformities and you just want to get it back into somewhat of normal alignment, but to be exact and really give your patient the best long-term result, I think using fluoroscopy, even though we have the sign nail, we know we can treat fractures without fluoroscopy. For this type of work, you need to be much more precise. And when we're using blocking screws, especially important to be able to have that crutch. Okay, and we just had a question. I'm just going to answer it in English. This is from Dr. Achelous in France. Bonsoir or bonjour to Dr. Achelous. He asked why we don't use a saw for this type of osteotomy. And in osteotomy work, I kind of divide osteotomies into two categories. There's the carpentry category and the biologic category. And this intramedullary fixation for osteotomies falls more into the biologic category. If you just use percutaneous incision less than 1 centimeter, drill a few holes with a sharp drill bit, and then crack the bone with an osteotomy, it creates like a closed fracture, and the periosteum is not disrupted, and osteotomies heal much quicker. They're much more forgiving, and you don't have to have exact carpentry in order to perform those types of osteotomies. If any of you have done lengthening, you mostly will know that it's impossible to produce regenerate when you use a saw. And the reasons for this aren't entirely known. It's thought to be because of heat generation. I also think that the irregularity of the osteotomy is helpful for healing, whereas if you have a saw, it just creates a really smooth surface. And the saws also disrupt the periosteum much more than the percutaneous osteotomy. So this is like having a fracture that occurs inside of a sock, and that sock just stays intact and produces the factors needed for bone healing. And there's another question from Dr. Shirley St. Louis. Est-ce que vous avez dans le suivi des cas de sous-arthrose? There have been some cases, especially when we've done lengthening involved with these two, where there's a partial healing of the cortex. We may have 1 or 2 cortices healing, and I had to go back and do some bone grafting. But in spite of leaving some open wedges there, like you saw in some of these cases, the osteotomies that we actually use the intramedullary fixation for and compress, it's extremely rare to have any pseudarthroses, and I don't remember ever having to go back and augment those or provide other fixation for them. And it can be, like I mentioned in the lecture, helpful to cut your osteotomy a bit above or below your apex, because then you can displace the osteotomy and pot that corner down into the medullary canal and get some actually pretty good bone opposition. Whereas if you do a pure opening wedge, it's much more of a biologic challenge. If you have a severe deformity, you need to stay a little bit closer to your apex than if you have a more mild deformity, because the displacement is much more displacement is required when you have a severe deformity. La différence entre l'axe mécanique et l'axe anatomique, c'est le degré de divergence qu'on doit tenir compte. This is, it's important to take into consideration the 7 degrees of divergence in a normal femur. Measuring the opposite femur is also very helpful for any given patient. And I think by knowing several different ways to measure these this anatomy, you can compensate for not always having the complete x-rays that sometimes we can obtain in institutions in North America.
Hey, Scott.
Yes.
How are you?
Doing really good.
Yeah, thank you for your support and your extraordinary work with young fellows and all orthopedic in Haiti. In the name of the Haitian people, I thank you, because I know you did a great job down there. I want to put some remark regarding this type of osteotomy, which is for me fabulous, using that sign nail, because all my residents, all my fellows, they know how to to put a sign in place. But you know, I am in Haiti and I was trained in late 1986. At this time, you know, I want you to ask you regarding plaster cast. When you got some young patient and you don't have all those facility, even though now we got signed, but you know, still I think that we have to cure some type patient. And for example, my young fellow, if they came to an area where they got only an operating room, a hammer, or a drill, even a manual drill, they can do a percutaneous osteotomy depending on the age of the patient and treat the patient and correct the deformity. Sometimes with a leg discrepancy, I know, but I want your advice, yeah, to be realistic.
Yes, I think we all need to not abandon those traditional techniques, especially when we're working in the challenges of the country that we live in. And especially for treating fractures, it's very important. It's very interesting though, because in Haiti at our hospital, we've collected a fair number of external fixators and we maintain them in good condition and reuse them. And it can actually be, I mean, if we're talking about expense, we always want to do the best for the patient. That's our primary priority. But if we are talking about expense, many times we can actually put an external fixator on a patient cheaper than we can put a cast on a patient. And it does also have the advantage of having absolute stability, and it's fairly easy to do. And so we normally tend to use external fixation in cases of children, tibia osteotomies, those types of things. Sometimes in cases that I may not even use an external fixator in the United States for a simple osteotomy because it's too expensive. I use it in Haiti because
Yes.
we have it available, and we can even give better treatment in Haiti because of that sometimes than the cost limitations that we have working in North America. So it's a little bit of a paradox, but I think having all the different tools in your toolbox helps you make the best decision for any given patient, and knowing these different techniques keeps you out of getting stuck in a rut of only doing one thing.
Yep, and I fully agree with you. And sometimes even in some situation, they can start with an osteotomy, you know, a closed osteotomy, put a cast on, and if they got leg discrepancy, they can send them back to the capital or to Adventiste. And I do a lot of leg lengthening with you know, any kind of external fixator, so that can help. Okay, so
Sure.
thank you, Scott, for your help again.
Oh, thank you very much. Very nice to see you, and the comments are appreciated.
We have another question from Dr. Woolley as well, if you'd like to ask it, Dr. Woolley.
Hey, Dr. Nelson, how are you? Good to see you.
Hello, Pierre. Great.
Yeah, great talk. I have a comment and a question. We've been doing, so we talk about femoral deformities, right? Most of the cases you showed were femoral deformities. What's your thought about tibial deformity, and what's your angulation not to go towards a sign nail? Because I actually personally got burned doing a tibial deformity correction with a sign nail and had to redo a cross-leg flap and a bunch of other reconstructions when a TSF could have easily done it and stretched the skin. So my question is, what's your angulation limit if you're doing a deformity correction? And the follow-up question is, when do you choose to go more conservative or with a TSF?
Yeah, I think that I can't really put a number on an angulation limit for a nail versus an external fixator. As a general rule, internal fixation is usually preferred by patients. And if there's a good way to use internal fixation, I try to make the effort to do that. But for the tibia, the TSF is so convenient. It's so exact. And for a mediocre surgeon like myself, I really like the TSF because I can put it on, and then when it's not straight at the end of the operation, I can go on my computer and type in a few more numbers and make adjustments. It's very forgiving. And especially in these cases where you have femur and tibia deformity, when you do these intramedullary techniques, there can be times where you leave the operating room and you end up being 5 degrees more or less than what you maybe anticipated. And usually if you have a TSF on the tibia, then you can compensate for that a little bit within limits, of course. And so I think for myself, especially in the environment that we work in, for the tibia, external fixator is very well tolerated. In the femur, they're not so well tolerated because of the soft tissues and issues with knee range of motion. And because of the exactness of the TSF, it's just a lot easier for the tibia. If you do have a lot of experience in tibial osteotomies using blocking screws, both lateral and posterior to your nail at your entry point to prevent the procurvatum and valgus deformity that tends to develop in proximal tibial osteotomies, it can work well, but it's still not quite as stable as TSF. Lots of times you have to give your patients more restrictions with that. And I think in any acute operation, any acute osteotomies for the tibia, you should consider prophylactic fasciotomies. And that's another thing that you can avoid with gradual corrections using TSF. And in general, it's more comfortable for the patients as well to have gradual corrections when we're in an environment where we don't have a lot of pain medicines, narcotics, etc. It's oftentimes more well tolerated using TSF.
Great point. Thank you very much.
We have another question from Dr. Grisi.
Hi, Dr. Nelson. Good to see you again. Thanks for a great talk. I think we're going to start using some of these techniques outside of Haiti as well. My question, though, is for residents in Haiti and all of us who want to get more familiar with TSF and putting on these telespatial frames and adjusting them afterwards. What is your advice to a Haitian resident who wants to learn, or young faculty?
Well, we welcome all of you to come and visit us at our hospital and learn together. There's a lot of places in North America where you can do observerships as well and learn from each other. I think that's a first step. And then the second step is really preparing your hospital to have the basic equipment. I spend a lot of time gathering equipment, organizing equipment, and fixing C-arms. And all of that is necessary for doing this kind of work. So I think if we all work together, we can do much greater things than when we try to do it on our own. I hope I answered all the questions that were in the chat. It was a little bit difficult to keep up with chat questions and audible questions and the lecture all at the same time. But if there's any other questions, I'm happy to answer, and I welcome all of you to keep in touch as well.
I think there was one question. It said for the second case, it seems you use 2 blocking screws, one on the medial and one on the lateral side. And how did you decide when to put a second blocking screw?
Oh, yeah, that's a very good question. The first case, actually, you might have noticed that I didn't use any blocking screws. And with the sign nail, the holes are slotted. And so in general, I will end up putting a blocking screw. But sometimes if the osteotomy really is able to be kind of compressed, that corner compressed into the metaphysis on the opposite side of the osteotomy, it can be so stable with a little bit of compression there, you may not even need any blocking screws. I think the general rule of thumb should be to always use a blocking screw on the concavity of your original deformity. And then that additional blocking screw, in that case, it probably wasn't completely necessary. It was a little earlier in my series. I've probably I probably tended more towards one blocking screw as I continue on, but it does keep it from going in either direction. So if there's any worry about it going back in the other direction, if you have bone that's not great quality, then adding another blocking screw is a good idea. And if you're thinking about it, you should go ahead and do it. And another thing that does influence the stability of these osteotomies is the angle that you cut your osteotomy. You can cut it perpendicular to your distal axis or perpendicular to your proximal axis. And there can be some advantages and disadvantages of either of those. I usually end up cutting my osteotomy about halfway. The angle of my osteotomy is about halfway between perpendicular to the proximal and perpendicular to the distal axis. And that usually creates enough of a corner in the fragment that's being displaced to kind of embed itself in the metaphysis and create some stability. And then going ahead and putting that blocking screw in the concavity is a good idea. So I think I just added that one. I was a little uncertain and it seemed a little unstable. So also the personality of your patient may influence that decision as well.
Amazing. Thank you, Dr. Nelson, for your talk and for your presentation. In the interest of time, I also we just want to close out our session today. But thank you to all of our presenters. It was really great having you, and all this information again will be saved and put up on the